Welcome to the Dental Implant Practices Podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Welcome back to another episode of the Dental Implant Practices Podcast. I'm your host, Philip Gordon, and today it's a special pleasure to introduce our guest, Dr. Cory Glenn. Dr. Glenn attended dental school in Memphis at the University of Tennessee Health Sciences Center, and after that was chosen to advanced education in general dentistry residency at Lutheran Medical Center. And you completed a yearlong AOS Comprehensive Orthodontic Curriculum. You have completed the yearlong AAID Georgia Maxi Course and been credentialed as an associate fellow in the American Academy of Implant Dentistry. You've also served as the continuing educator director for the Tennessee Academy of General Dentistry and the president and CE director for the Middle Tennessee Dental Club. Dr. Glenn, thanks for coming on our show today, and I really appreciate having you on here today.
Well, thank you for having me. I'm enjoying doing it.
Yeah, so we've never actually met. But I've followed you on Dental Town and have come across some of the things that you're doing. And for people that don't know your story, why don't you start off just kind of telling me about after you graduated dental school, kind of what you've been up to and what your path has been leading up to now. I know you've had a lot of big things happen in your career personally and professionally. Why don't you talk about those?
Yeah, sure. So that could be a long story, but I'll go ahead and give it a try. So I went to UT Dental School and, actually went thinking I wanted to do oral surgery. But, once I got there, I kind of realized I liked all the general dental aspects and could still do a lot of the surgery. So ended up doing that, but I wanted to do the residency so that I could get my hands on some implants, start doing some more complex casework. And so did the extra year in Memphis and really enjoyed that. I got to learn a lot from Dr. Steve Cloyd, my residency director, about implants. He was kind of one of the early guys to jump on the implant bandwagon, so he had a lot to offer there. And then following that, we ended up buying a practice in Podunk, middle of nowhere, southern Middle Tennessee. And so the doctor that was selling the practice was actually ill and had a brain tumor and was having to sell. So we purchased the practice. And it was just trial by fire. There was no transition period or anything like that. It was just we jumped in and just started working on some teeth. And thankfully, it was good to us. And we've made a great living there and love the area here in Middle Tennessee. And I was kind of suspecting that along the way I wouldn't be doing a whole lot of implants, ending up in a rural area like this. And for the first, maybe 4 years or so, that kind of held true. We were rocking along doing 15, 20 implants. And eventually I did take the AAID Maxi Course, which was a big help to me, gave me a lot of confidence. And then the other big thing that I think skyrocketed me to doing more implants was to actually get a cone beam. And so what I found was that the first year I got my cone beam without doing any different marketing, really no changes whatsoever, the number of implants we did just doubled. And so I realized that, one, it was a big hindrance to have to refer people out for that. People didn't want to leave the office. And then, two, I realized that it actually gave me a lot more confidence to treat more cases that I might not have done without the cone beam. So that really kind of skyrocketed us. And then moving on from there, I started getting into the guided surgery stuff. And really that's what I've been spending most of my time on since then, is trying to develop new ways to do guided surgery, to try and keep the costs down. And really a big part of that has been the Blue Sky Bio software. And for those that might not be familiar with it, the Blue Sky software it's a free software. Anyone can download it. It allows you to merge cone beam DICOM images and an STL model, and you can actually generate guided surgery stents for any system on the market, totally open source. And, I went wild with all that. I bought the 3D printers, the whole 9 yards, and really at this point, we've got it down to the point where we can plan a 3D guided surgery and print the guide in office, and I've got the whole process down to about $20. So very affordable, and boy, it sure makes my life easier as far as workflow and efficiency. So that's something that I've really enjoyed doing in the last I guess, 2 to 3 years now is what we've been doing the guided surgery.
That's fantastic. Yeah, I can speak on that CT also. As soon as you buy a cone beam machine, you just see things differently. And I don't know if it's your confidence or your you train yourself up or what. You automatically start placing 2 or 3, 4 times as many implants because you see things for what they really are.
Absolutely, and that was totally unexpected to me. I really didn't anticipate that at all when I bought it. I just wanted to have the technology because I kind of felt like if I was going to be doing implants going forward, it was just something that I needed to have. So that was a totally unexpected but very welcome byproduct.
Yeah, I can definitely say that was true for my path too. So now you're just getting over a recent health problem. Why don't you tell everyone how you're doing? You said you're on your way to recovering. So tell everyone what happened with you in your last year. I know that's been a big deal for you.
Sure, yeah. So 2015 had a huge year. Really was doing great. I was doing tons of implants, lecturing a ton on guided surgery, traveling around, doing a lot of cool things. At the age of 33, I had pretty much accomplished what I had considered success to be at that point in life. But by the end of the year, I was just really tired, worn out. My back was killing me. And so finally, when I was doing an extraction one day and my hand cramped up around the forcep, I thought, well, I've got to go to the doctor. So went to the doctor. They did some blood work. And I got a call at the office a few days later that they had gotten the blood work back, didn't look good at all, and that I needed to go have a bone marrow biopsy. So I automatically knew something was up and had the bone marrow biopsy done. And then the day after Christmas of 2015, got the call that I had AML leukemia. So big scare, a quick Google search told me that I had about a 30% chance of living at my age with AML leukemia. So pretty serious scare, and all the dentistry and the speaking and whatever financial success all became pretty unimportant at that point, and really refocused me on what is important, my family, my faith, all of those things. And so went into the hospital, spent a month in isolation there because I had no immune system, hardly any blood cells left. And I did get the good news that I actually had a rare subtype called APL leukemia. And so APL used to be the most deadly form of leukemia that there is, but nowadays they have a really successful treatment regimen. And, I went from thinking I had about a 30% chance of living to over a 90%. So we did the treatment. I did chemo for 8 months, and thankfully everything was successful. And a couple months ago, I did get an all clear on my most recent biopsy. So they say I'm in the clear as far as the leukemia is concerned. So I did develop some back issues during that time, in addition to the leukemia. So I'm still trying to get over those. I'm currently not back to practicing full time yet. I'm doing about 4 hours a day. And that's about all I can handle at the moment, but hopefully trying to work myself back up to normal hours again. But it was an interesting year. It wasn't how I planned on spending my 2016.
It's good to hear you're back at it and over that big scare, but I can imagine that really shook you down to your core and made you definitely appreciate and approach life differently.
Oh, absolutely. It's changed everything in that respect. So in a lot of ways, I'm very grateful to have had cancer. It's not fun or anything. It's not something I would recommend, but there's been a lot of good things like that come out of it. So I'm grateful to be where I am.
Let's talk a bit about your involvement with Dentaltown. I know you've got some interesting posts there, and in a particular one, you've got one that says, what is it, Cory's Pearls on Implant Dentistry? Is that what it's called?
Yeah, I think so. That came about. I was making a handout for a course I was teaching, and I thought, well, heck, I just might as well throw this up on Dentaltown and see if it's helpful to anyone else. So there was a big response to it. I didn't really expect all that, but hopefully it was helpful.
Yeah, so on there you talk about a lot of things as far as your guided surgery and all that, but you also talk about some extraction and bone graft technique and all that. Tell me how you got some of your training with bone grafting and the guided tissue regeneration and all that. What's a good pathway look like for somebody if you're going to say how to get more exposure for those sort of things, or how to come across good bone grafting material? Because I think that's somewhat confusing for a lot of general dentists out there.
Yeah, sure. So, just basic socket grafting, I think is relatively straightforward. And, the most bigger conferences will have, usually a morning or an afternoon course that you can do on just basic socket grafting. And there's a lot of different ways that you can approach it and be successful. I don't think there's any one set way, but I do think socket grafting is important. That's kind of the foundation for learning more advanced bone grafting, and it's also the foundation for having good implant sites to go back into. And so that's a really important thing. Now, as far as the more advanced grafting stuff, I don't know of just a single course you can go to for that. I did get a lot of exposure to that in that Maxi course. The Maxi course I did was pretty intense. It was 10 4-day weekends. So it was nearly 400 hours of CE. So got a lot of exposure to things there. I've spent a lot of time on Dental XP and Dental Town doing courses and videos. I've actually never done any of the more hands-on type bone grafting courses, although I think they'd be a great investment to do. But most of what I've done has come from online learning or classroom style learning.
What are you currently doing for a socket graft? What's your secret sauce for that?
Currently, what I'm using is the Maxius 50/50 mineralized demineralized bone. It's a good price. It's been a good product. Most of the sockets I go back into after placing that have been good, nice bleeding bones. So the Maxius cortical cancellous bone, and then I mix it with a bone binder called Fusion. And so that is, it's a mixture of calcium sulfate, which is medical grade plaster, carboxymethylcellulose, and gentamicin. But really, all it does is it gives it more of a putty consistency. And it purely, for me, the only reason I use it is that it improves the handling. So it turns it into a nice putty that's easy to pack in there. And the calcium sulfate gives it the ability to kind of set up. And so, sometimes you can do a little buccal onlay graft and it'll actually kind of function as its own membrane. So that's been a nice product that I learned from Jerome Smith. He kind of turned me on to that at his course down in Louisiana. So yeah, that's what I'm using for socket grafts. And then I usually cover it with a Cytoplast non-resorbable membrane. I really like those just because you don't need primary closure. Which is pretty difficult to obtain in a molar socket. So molars, I'm putting that Cytoplast membrane in there. In anteriors and premolars, where it's a smaller diameter socket, usually I will just use some slices of CollaPlug. I'll throw a bunch of sutures over that, and then I'll put some medical grade super glue over the top of it to seal it.
That binder, do you feel like that helps set it up like in a maxillary molar, kind of helps hold it in place, and then you're not having
for sure.
You're not having to wash out as much over the next couple of days while that blood clot's setting up over there and all that. Is that the idea behind that?
Yeah, I mean the idea is primarily for the placement. I mean, if you've ever tried carrying just granules in there and then getting them packed into the apex of a palatal root, you know what a struggle that can be sometimes. So my main use for it is just to improve the handling. It turns my bone into like a dough ball, more or less. And so that's why I like it. I couldn't tell you any of the histology or anything like that as far as how it changes the healing, although calcium sulfate has a lot of literature behind it as a bone grafting material. But again, for me, it's just about the handling. And again, it does set it up a little bit. And so it makes everything thereafter, once you've packed it in, easier. You can rinse it off. It's not going to squirt your bone out. So it's really just a nice product.
Now, you said you're using non-resorbable membranes for those molars. So talk me through that a bit. Are you going in for implant placement and removing those later, or?
No, with these Cytoplast membranes, what you do is you just barely tuck them under the buccal and lingual flap, and it's Teflon, and so very bioinert. The tissue responds very well to it, just like the Teflon sutures. That's what I use for my suture material as well. But it's just easy to place, and then you'll come back at about the 3 to 4 week mark. And usually you can just tease an Explorer tip under that and just pull it out with no anesthesia or anything. And it comes right out. And usually you can see a bed of osteoid there. and it allows everything to granulate in over it. So whereas, if you were trying to use a collagen membrane and get primary closure, you might have to release your flaps. And in doing so, you end up pulling the keratinized gingiva, too far in toward the lingual or the palatal, and you lose keratinized gingiva in that process. With these, we don't make any attempt to get primary closure. We simply lay the flap where it, laid before the tooth was extracted, and then the membrane covers over that area where, we want the keratinized gingiva to fill in. And so, again, when you pull that out at 3 to 4 weeks, everything under there is the early stages of keratinized gingiva, and it really grows over nicely and gives you a nice bed of thick tissue to use once you come back for implant placement.
Perfect. Now, you think that works better than just the basic resorbable membrane that you can place over there and just allow non-primary closure also?
I haven't had a ton of success with leaving like a collagen membrane open without primary closure. I know a lot of people do it, and I've certainly heard of people, but I had a few cases. I wouldn't say a lot. I've had a few cases get infected doing that, and so just the ease of being able to tease this stuff out at 3 to 4 weeks. And not having to try and get as much closure, those to me have been big advantages. And the other advantage is that they're really cheap. I mean, they're like $40. The cheapest collagen membrane I've ever seen is over $100. So that plays a big part in it too. And if you give me two products and tell me that they'll both work equally well, I'm going to always take the $40 one over the $100 one.
Absolutely. You always got to be mindful of the business decisions there. So.
Sure.
Tell me about a moment about that. You said medical grade glue you're using to kind of glue some of those primary closure sites back together. What are you using for that?
It's called periacryl, and I purchased it from Salvin, but it's just medical grade super glue. And so Anthony Sklar has a technique. I forget the name of the technique now, but he was using BioOS, and then he would cover it with a slice of Coloplug and suture it and then use this glue over it. So I'm stealing the latter portion of that technique, and just in smaller sockets where the diameter of a Coloplug more approximates the diameter of the socket. That works really nicely for me. In a molar, I tended to have those come out just because you couldn't cover the whole socket, and so I would end up getting premature particle loss at the crest of the graft. And so I like a membrane better for a big molar. But smaller teeth, that technique works really well with the periacryl.
Now, do you keep some of that at home just in case you get a cut also and just kind of glue it back together? Can it work for that?
I've not tried it, but I'm pretty certain you can. I think emergency rooms use it for that purpose, actually.
You just gave me more than one idea there, so that sounds like something to keep at the office and maybe in your truck also. So.
Yeah, absolutely.
I know you're real active with Blue Sky Bio. Tell me how it is you came about that relationship and what you're doing now and what you see yourself doing in the future with them. I know you've done some lecturing for them, and I've seen some videos that you've posted. Kind of tell me how that whole thing started.
Sure, yeah. It actually just started with me using their products. And so they didn't seek me out as any kind of key opinion leader or anything. I was just using their products and very happy with it. But what really broke it wide open was when I jumped on the guided surgery bandwagon. Again, their software being free and open source really opened a lot of doors, because prior to that, your cheapest option to do guided surgery was, to pay $4,000 or $5,000 for a software, and then $300 to $500 for the pleasure of using it every time you wanted to make a guide, which was just bonkers to me. There's no way I was ever going to do that in my area with the fees I can charge. So for this to come along and to be able to generate cone beam guided surgery guides for less than $50, now we're talking about something that makes financial sense. And so I got into that and really took off with it. And again, just posting stuff on Dental Town, I guess a few people started to take notice of it, started lecturing. Armin Mirzayan, who's a big name in the CAD-CAM and the guided implant world, began talking with me and asked me if I wanted to do a guided surgery course with him. So we did that, and that has really taken off since then. And we do it probably every other month now. Myself and Armin and Dr. Baron Grutter also joins us oftentimes, and Dr. Joseph Wynn. So we do these courses. We go around the country, and we've got ones coming up in New York and Boston and Lafayette, Louisiana, and then Baton Rouge, and then Miami. So there's a lot of these on the schedule, but it seems like there's a big market for people wanting to learn this guided surgery process and to be able to do it themselves and not have to outsource it and pay crazy fees to be able to do it. So that was kind of the connection with Blue Sky. Was doing all the lecturing and stuff somewhat apart from them. That was really just something myself and Armin started, but we were mainly using their software, and they were kind enough to give us some implants to use in the courses for mock surgeries and things like that. So I had a great relationship with them, but then actually when I got diagnosed, I was sitting in the hospital one day and was sitting there griping about, how I had no income and I was bored to death and all this. And Sheldon, one of the owners, calls me and asked me if I'd like to work for them doing customer service calls and emails. And so for the next 6 months or so, I actually did that and actually worked for Blue Sky Bio. And so that was a godsend for me because it gave me a little income and kept me from going crazy and kept me in the implant world while I was out sick. So I really have nothing but the highest regards for that company, for the owners, Sheldon and Albert. They are really some tremendous guys, and I'm more of a fan after having worked for them than I was before. I mean, to see how the company operates, I'm just a huge raving fan of them.
That really says a lot about somebody, when you like them more after being, an employee of theirs or affiliated with them, because that's, that must say a lot about them.
Yeah, it really does. I think the world of everyone in the company. They're on the cutting edge. They're a small enough company that they're able to be nimble. So, when we have a course and someone comes up with a good suggestion for the software, within a month or two, it's usually incorporated into the software. That's not the kind of, you can't see quick movements like that with some of these behemoth companies that have to run it through 15, different bosses and marketing and all that. So they're just a great company. I love them. Keep their prices fair. They're not out to gouge anyone, and they just give a solid product at a good price.
I mean, that's all the things you want in a company that you work with. So
yeah.
I know you've probably used a lot of different systems. I assume maybe you're just using those Blue Sky Bio implants fairly exclusively now. Is that right?
Yeah, that's really, I'm placing the Blue Sky Bio Biomax implant. They have a number of different lines, I think 6 lines of implants, but that's the one I'm placing. It's got a Nobel Active compatible connection, and it's been really good in my hands. I've enjoyed using that.
So it's got a conical connection, just like the Nobel Active would, and kind of has the same body and thread design as the Active would.
A little bit different on the exterior surface of the implant, but if you've used a Nobel Active, they're going to handle fairly similar to that. They both got pretty aggressive threading on them, and get a pretty good bite in the bone. Yeah.
Now, what is your kind of go-to process if someone comes in and they've got maybe the bone for an implant? What's your kind of workflow look like? If you can explain someone kind of A to Z, getting them into in your office and getting them out with a tooth. What's that workflow look like?
I'll on the consult, if they're a candidate for an implant, we'll go ahead and if they want to proceed with it, we'll actually get a PVS impression of their mouth. And one of the neat things in the Blue Sky software now is that you don't need an intraoral scanner or a lab desktop scanner. You can actually put that PVS impression into your cone beam, scan that, and the software will actually turn that DICOM file of the impression into an STL. And so that gives you your STL of their arch. You merge that together in the software. You can plan it out. I would say a typical case takes me between 5 and 10 minutes for routine single tooth. And once you do that, it's going to spit out a file for the guide, which you can 3D print. Again, I've got a couple different 3D printers in the office, so I do it right then and there. And so it's very feasible for someone to come in. If they wanted to come in at 8 o'clock in the morning I could have all of this done and the guide printed by before lunchtime. And if they wanted to, just go ahead and do the surgery. Now, we don't ever try to rush it that much, but it's certainly doable. So, we've got the guide generated, go into surgery. We'll lay a small flap. Even though I do everything guided, I almost flap everything because I want to maintain keratinized gingiva. I'm also a fan of two-staging implants, so I like to bury them and let them heal undisturbed, and that gives me the ability to lay a flap back over it when I do that. So make a conservative crestal flap. I'll seat the guide, and then 1 or 2 drills through the guide, and then the implant goes in. So, the implants are usually a 10-minute procedure as well, and very predictable in where they end up in the bone. And then I'll bury it and come back in 3 to 4 months and uncover it, and then I'll try to make a lingually displaced incision, roll all that keratinized gingiva to the buccal so that I gain some keratinized gingiva on the buccal, and usually give that 2 weeks, and then take a fixture level impression. And then here lately, I've been lazy and just sending off for custom abutments and zirconia crowns. If I've got more time and the will to do it, I'll use what's called a multi-purpose abutment, which you can use as the impression transfer, and then you can actually prep it, and that can become your final abutment. But again, I'm just kind of being lazy here lately and letting the lab do it all. So that's more or less my process.
Well, that's great. I mean, it sounds like you've got things figured out for sure, and I know that's been a long journey for you. You didn't start out doing all that, at that pace and that rate. Tell me why. No. Yeah, tell me why you're burying the implants and coming back and placing your healing abutment later.
Well, a couple of reasons. One, I've noticed not a big difference, but a slightly higher success rate in implants that I've done that way. I seem to see less risk of early infection, which makes sense. If you've got a healing abutment on there, there's a track for bacteria to travel down to the implant surface. And if you get some bad bacteria colonized down there early, that can lead to a surgical failure. So, again, not a big difference, but I have seen a little difference in that. I've also seen a slightly higher incidence of just prosthetic failure when I've done a one-stage implant because, again, implants at about the 3-week mark, they're at their weakest. And if you've got a healing abutment in there, the first week or two, the patient remembers and they're careful not to chew on it. And about week 3, when it's at its weakest, is when they forget about it and they're chewing and they've got, tuna salad going down beside the healing abutment. They're putting stress on it, micro movement of the fixture. And so, although it didn't happen often, I would sometimes come back and, at the time to test the integration, I would put the torque on it and the thing would spin. And so I didn't have much of an explanation for that other than, it probably just got fibrous encapsulation because it was moving around during the integration period. So for those reasons, I just, I like to stack the deck in my favor as much as possible. And so if doing a 2-stage procedure is going to do that for me, then that's what I'm going to do.
Yeah, that's interesting. I do when I place all my implants, I put in a healing abutment. But there have been a couple times where I've gone back to change that out, and there hasn't been any infection necessarily in the implant, but I've come back at maybe like the 3-month mark, and I was going to go unscrew my healing abutment, and the implant was unscrewing. And I've always and that's only happened a couple times, but I've wondered how did this happen? Because I remember upon insertion, I had good insertion torque. I did my antibiotic regimen and my mouth rinse regimens, and there was never any signs of infection in the gum tissue or the implant, but there was movement at that implant. So I've always kind of wondered, would that have happened if I would have buried the implant? But that's only been 1 or 2%. So
yeah, it's a small percentage of cases. I think. Depending on the practice and how busy they are, a lot of my friends are even into immediate loading and stuff, and they're willing to trade a little higher percentage of failures or problems for the convenience that affords them. And I don't think that's a wrong answer. I just hate going back and dealing with something after it's failed. I mean, those to me are harder those are the hardest cases to come back after something hasn't worked and now figure out how to make it work the second time. So again, I do everything in my power to try and make it work that first time. And it's a little bit of a pain to do that uncovery appointment, but it's a suture and a 15 blade and a couple of weeks of additional time. So it doesn't bother me too much.
Yeah. And that's definitely something I'm going to reevaluate. I'm always looking at if I get a failure, which isn't very often, what is it
Sure.
and why? And is it something I'm doing or is it the patient? And that could definitely be something to reevaluate, but I'm fairly traditionalist too. I don't want to get too progressive. I've done one or two of all of them and figured out what handles well in my hands and what doesn't. And you kind of, I think you determine, like you said, you narrow it down to what you want to do in your practice and what you're comfortable with, and go from there.
Yeah, and again, you mentioned it's tough sometimes when you have a failure you really never can put your finger on exactly what it was that went wrong. And so it's entirely possible that the few failures I had that I'm blaming on this are something else entirely. But I guess you all get skewed by our experiences with things like that. So anyway, that's what I'm doing now. I've done a lot of single staged implants as well, and they work fine. I've done immediate load implants that worked fine. I've done immediate load implants that were a miserable failure. So, again, it's just hard to pin down sometimes the cause of what the issues are.
Yeah, I've done every type. I've done all types of stages, and I've had all of them work, and I've had one of every kind fail. So I definitely agree with you. There's not an exact, do it this way every time kind of protocol. But,
yeah.
Definitely getting comfortable with what that you can control and move forward with that.
Right.
So I know we've talked a lot about courses and materials and things like that. What are you curious about right now when it comes to implant dentistry? I know you've been exposed to a lot of things. What's on your mind as far as this next year, other than getting healthy and getting back to practicing more? If that were to happen and things go good for you, what would 2017 bring for you as far as your curiosity and the direction you're going?
What I am focused on right now is not as much the placement, but the prosthetics. And so a couple of things have my interest right now. One is a technique that I actually worked on it some today to be able to deliver a hybrid for under $500 that you can do mostly in office with not super technical lab work. I think full arch dentistry is out of reach for most people because the costs are so high on our end. The last hybrids I did were $2,800, and that's not an outrageous fee. I've seen them go as high as $5,000 to $10,000. And so when you're having that kind of a lab bill, you've necessarily got to charge a boatload on the actual fee for the procedure. So if we can get the lab fee down for these full arch prosthetics, I think that's going to go a long way in opening them up to more people. And so a couple of different techniques that I'm looking into. One is the CAL technique. You'd have to probably be an old white-haired lab guy to know much about that, but really an amazing technique that I'm trying to revive. I'm also looking into being able to digitally print bars. And so kind of on the heels of that CAL technique is being able to design the bar in the software, print that in a castable resin, and invest it, and then have that metal bar generated that way. And then I also am trying to look into some of these options for telescopic things. I think once you've done a few hybrids and you've had to find 6 screw access holes and torque everything down and close them with composite, it's a half a morning appointment just to get one off and back on, just to check something. So telescopic type cases or patient removable implant bridges, things like that, those are really what has my interest at the moment.
Yeah, those are kind of the next level dentistry, and those are definitely complex, and there's a lot of moving parts there. So now, when you're talking about full arch cases, are you talking about maybe like a Zest retained overdenture? Or are you talking about screw down hybrid zirconia cases or PFMs? What are you doing in your practice, sir?
Any of the above. I think PFM. I think my favorite thing to do is probably a PFM roundhouse bridge. Or if I can, break them up into 3 different bridges, maybe a 7 to 10, and then first premolar to first molar. That's probably my favorite way to do it. I think the patients are the most happy with that. But, sometimes we got to replace some pink, and that doesn't always work. So the most recent hybrids that I did were Smart Composite. I don't know the exact brand name on that. Burbank Dental Lab does them, but they're a really nice option. That's a titanium milled bar, and then they mill out a composite puck. So you get a monolithic tooth prosthesis, and those get bonded together. So that's what I've done recently. I'm totally trying to get away from, just the flat featureless titanium bar with denture tooth and acrylic. I've got one of those that's just a nightmare for me right now, popping teeth off. So I really want to get away from those. All the techniques I'm exploring that still use denture tooth and acrylic, I want to have a metal retention inside of each tooth. So that's important to me. I think a lot of times you can get these really good deals on hybrids for, $1,100-1,200, but man, they can be just an utter pain in your neck for a long time if they start breaking things. So yeah, doing that. The other option that's kind of cool that I've been looking into is the patient removable implant bridge. So Mike McCracken down in Birmingham at the Foundry, they do a lot of these. And so, for example, let's say you had 6 implants in the maxilla. What they'll oftentimes do is either make custom abutments or just prep stock abutments to within parallel on the front 2 and the most posterior 2. And then on the middle 2, they'll put a couple of locators on there. And so you kind of get an effect of a telescopic on those custom abutments, and then they get retained by the locators. And this is a fully fixed when it's in there, but the patient is able to pull it out and remove it. And so it really brings lab costs down because now you're more or less talking about, 4 abutments, 2 locators, and probably a similar charge to what a partial denture would be. So you're at under $1,000 to pull one of those off. And they are really nice. They're solid in the mouth. They're repairable, which again is a big thing for me. Being able to just pop that out and hand it to the lab is very nice to have, as opposed to having to go digging through the composite and finding screws and all of that.
Yeah, no, I've seen something similar to that. What are those made out of? Are those acrylic? You said those are a metal base with.
Yeah, those are more or less made like a horseshoe denture. It'll be a metal framework, and then they'll put denture tooth and acrylic into that. But again, you can either go directly, do pickups directly onto those parallel abutments, or you can make a little cast metal coping that goes over that and pick that up in the denture, and then just, your locator type housing for the middle ones.
Sure. Now, doesn't Ankylos have something like that too? I don't know that I've used that, but.
Yeah, they've got the Syncone abutments. I've not ever used them. Yeah. I don't know a lot about them, other than I've heard the cost is somewhat high to do those. So
okay. I
love the telescopic option, but man, they're so expensive to do. So I'm trying to find ways to get the cost down on that.
Those are all great points, and I've done a fair amount of those, and I think there's good and bad with each. They're removable. It's cheaper, keeps the cost down. It's repairable, but patients want something that's a little more fixed and maybe a little more aesthetic, and then so you go into the ones that are screw down, but those are a chore to take on and off, and or the PFM bridges, can you get them off and repair them, or the zirconia, those are a big deal, but maybe high risk, high reward for those. So I mean, there's all these different types of changing options right now, and I think trying to put all that together is kind of where I'm at too. Doing a lot of those cases, how to make things easiest, most predictable, that'll last the longest for patients while keeping the cost down, right, and getting more patients into the care that they need and deserve. And I think that's a constant tug on both ends of that rope. So.
Oh yeah, and that reminded me, you asked about what else I'm kind of digging right now is I'm looking to get into in-office milling of zirconia. And so buying more of a lab geared zirconia mill that would give me the option of milling out hybrids or horseshoe bridges and things like that. Because, those things, if I had the ability to mill it and do it all myself, I'm a little more inclined to push the envelope, because if something fails, I'm happy to redo it at no charge, and it won't cost me a whole lot in materials as well. You always hate to try new things when you have to use the lab and pay full lab bill, not knowing for certain if something is going to work well. So being able to do things in-house, to me, gives me a lot more confidence to try different things and see what works and what doesn't.
Yeah, absolutely. You don't have a problem warranting your work, but if you're trying something new, you want the lab to do that too, and they're just not going to do that. So, there's a healthy respect for that that's got to be balanced.
Yeah. And I understand on their end that, if we're telling them to do it and we're pushing the envelope, then they're probably going to say, well, you live with the consequences. So I don't mind living with the consequences, but if I'm going to try stuff like that, it sure helps if I would only be out a $200 zirconia puck as opposed to a $1,200 bridge that the lab did for me.
I've kept you here for about 45 minutes, so we'll wrap up soon, since I know you're a busy fella and have a lot to do. And like I said, we may just have to have another conversation another day. But what would be I always ask my guests, what would be the 3 best practices that you have in regards to the way that you practice? If there were 3 of your top pearls, as you would put it, on things, what would be those 3 biggest things that you think make the biggest difference for how you practice and that you would share with other people?
So probably my number one, and what has built my career more than anything, is to document. Pictures, as many pictures as you can possibly take of your surgeries, of your restorative, and that serves multiple functions. One, you can't help but take a bunch of pictures of things like that and then look at them, with a 18 megapixel picture where you can zoom in and see an amoeba. That is going to make you better, because you can't look at your work magnified that much without flaws standing out. And it's going to make you better. And secondary, it's going to serve as your marketing material. And so you might do great work, but how does anyone know? Are they just supposed to take your word for it? Do you have anything you can put on your Facebook page or your website or share on forums or things like that? If a patient asks about a particular procedure, it sure does build a lot of confidence to say, oh yeah, we've done one of those. Here's what that would look like. So documenting, to me, is the number one thing that people need to do. I just can't tell you how much that has built my career, not only professionally, with other dentists, but also with patients, being able to show them what we're capable of. So documenting, technology. Technology has built my career as well. Of all the technologies I've owned, and I've done cone beam, CAD CAM, I've had a CERAC, lasers, you name it, microscopes, whatever. But of all the things that I've had, really, to me, cone beam is the most indispensable. I would want to not practice anymore if you took my cone beam away from me. For all those reasons we talked about earlier, the increased confidence. I'm such a fan of guided surgery. It would be hard for me to go back to freehanding everything just because I've seen how easy it can be. So the cone beam and technology in general is a big thing for me. And the other thing I would say with technology is make sure that your patients are actually seeing you use it. And so I try as often as I can, if we're planning an implant case, I try to do that planning right in front of the patient. Because you'll just see their jaw drop. They just had no idea that this Star Wars type stuff could be done. So I think that's important. I think it has a huge wow factor for your patients. And I think it can raise the level of dentistry that you're doing. And then what would be a third one? The third one, never stop learning. You just, whatever you're doing today, if you're doing the same thing in 5 years, you're doing something wrong, because everything else is going to advance. and you got to advance with it. And so try to be a continual student. And even if you feel like you've arrived, you can always go to the next course and get that next pearl that can take you to the next level.
Yeah, those are great tips. Like you said, I'm just the biggest fan of cone beam. I do some form of guided surgery on all mine, either usually just pilot drill guided,
Yep.
but I definitely don't do implant surgery without having taken and seen and viewed a cone beam and have some sort of guide.
Yeah.
Not that I couldn't, but after you own a cone beam, you don't want to go backwards in time,
Yeah, for sure.
And those are great tips. Definitely appreciate you talking with me tonight. If somebody was wanting to get a hold of you or take one of your courses or sign up for Blue Sky Bio, what's a great way to either get a hold of you or somebody with taking one of those courses? What's the best way?
We actually offer a website, so blueskybio.academy, and that has links to all of our courses. You can register online, and we've also got a membership-based portion to the website. So if someone didn't want to come to a live course, but they wanted to learn it all online, they could sign up for the website membership, and there's a pretty exhaustive video library that you can learn pretty much guided surgery from A to Z. So you can get through that. I'm always pretty easy to contact through Facebook, Dentaltown, all of that kind of stuff. If you wanted to email me, you can email me at Cory@blueskybio.academy. So yeah, anybody can get in touch with me through those.
That's great. I think what you guys in your companies figured out, or you and the people that run that company has figured out is, giving away that information is going to want people to take your courses and buy more from you. So the more information.
Oh yeah, you can't give away enough to make people stop wanting it. I mean, that's something I've really learned over time. A lot of people want to be stingy with their material and make you come to their course and just give you a teaser. But honestly, I found the more you give away, the more people want to hear you.
And I couldn't agree with that more. And that's really what attracted me to you and your group, because I've spent a lot of time and energy trying to chase down the best information, and usually the guys that are giving away for free have it all figured out and have the best stuff, and so there's nothing to hide. So I really respect that about what you guys are doing and Blue Sky Bio. So,
well, thank you.
I'm going to start drinking the Kool-Aid here soon. I'm just like I said, I'm getting it out there for everybody now, and I'm going to look at. I haven't actually placed a Blue Sky Bio, but I think my next couple cases I may give them a try and see what I can do from there. So,
cool. Yeah, I don't think you'll be disappointed.
Yeah, hope not. So, thank you for your time today, and I know you got a busy evening ahead of you. So, best of luck getting your strength and energy back, and I may try hitting you up here maybe over Christmas break when things slow down, and we can catch up and kind of connect again.
Okay, that sounds great.
Great. Thank you so much. Bye-bye.